Good morning. My name is Nancy McAuliffe, and I am a representative of the Maryland Department of Health and Mental Hygiene. I'd like to welcome you to the second breastfeeding educational webinar for healthcare providers. Today, you'll hear the presentation, Helping Your Patient Succeed, Prenatal Support, Delay in Lactation, and the Infant Who Won't Latch. This program is part of the Maryland Department of Health and Mental Hygiene Hospital Breastfeeding Policies Physician Webinar Series. After completing this presentation and successfully completing a post-test, physicians will receive 1 hour of continuing medical education. The CME will be available through June 2019. DHMH thanks LifeBridge Health and Dr. Dana Silver for partnering with us to make this possible. Per DHMH policy, we remind our listening audience of the recommended steps to reduce contracting the Zika virus, which can cause serious birth defects. Citizens are advised to avoid mosquito bites, use insect repellent, and empty containers of standing water. This slide pictures the species of mosquito that spreads the Zika virus, and here are websites that you can access to find more information. I now want to move on to our presentation. Your speaker today, Dr. Ann Eglash, is a clinical professor with the University of Wisconsin School of Medicine and Public Health in the Department of Family Medicine. In addition to practicing family medicine, she has been a board-certified lactation consultant since 1994. In 2013, she developed the Outpatient Breastfeeding Champion Training Program to teach breastfeeding knowledge and support to the primary care medical offices in the University of Wisconsin Medical Foundation System in Madison, Wisconsin. Ann is a co-founder of the Academy of Breastfeeding Medicine and is the co-medical director and co-founder of the Mother's Milk Bank of the Western Great Lakes. She is the medical director of the Outpatient Lactation Program at Meriter Hospital and the medical director of the University of Wisconsin Lactation Services. She has published many peer-reviewed articles on breastfeeding medicine and sits on the editorial board for Breastfeeding Medicine Journal. She co-hosts and produces a free breastfeeding medicine podcast series, the Breastfeeding Medicine Podcast, which can also be found on iTunes. Welcome, Dr. Eglash.
Thank you. Thank you for having me. So what we're going to do is cover 3 specific topics, one on prenatal support for healthcare providers in their offices. The other, we'll talk about a delay in lactation and a quick overview of how to manage that. And then we'll talk about the non-latching infant. So our objectives today are first to identify 3 ways that physicians and other providers can provide breastfeeding support and education for families prenatally. We'll then talk about 2 reasons. Well, hopefully you'll be able to recite 2 reasons for a delay in lactation, and that you'll be able to describe 2 steps to protect breastfeeding when there's a delay in lactation. Hopefully you'll be able to identify 2 reasons why a baby may not latch soon after birth, and describe 2 steps that will protect breastfeeding when the baby will not latch after birth. So first let's talk about prenatal support. So the question is, who is most likely to initiate breastfeeding in our country? Well, the CDC collects a lot of different information based on different types of surveys that are sent out to cohorts of families. And so as of their 2013 national immunization data, we find that people who are more likely to initiate breastfeeding are those who are highly educated, have a higher income, live in metropolitan areas, and are over age 30 as compared to ages 20 to 29. They didn't collect very much information on people under 20, but that group of individuals are probably less likely to breastfeed. In terms of races, that's actually switched a little bit, because it used to be that Hispanics were in a group that were less likely to breastfeed, and now we see that they're in a group of that's more likely to breastfeed, in addition to Caucasians and Asians and Pacific Islanders, whereas Native Americans and African Americans are still the groups that have lower rates of breastfeeding initiation and duration. So what's really encouraging is that the United States Preventative Services Task Force in 2008 reviewed the data on whether what we do in the office and what we say to our patients makes a difference in terms of breastfeeding initiation and duration, and they found that indeed it does, which I think is amazing, because I oftentimes find that the United States Preventative Services Task Force does not often support the things that I do as a primary care provider. And so they find that training of primary care staff, in addition to the knowledge of the primary care providers, about breastfeeding and techniques to support breastfeeding have been shown to increase breastfeeding initiation, duration, and exclusivity of breastfeeding. And if you want to learn more about that policy, about their statement, I should say, I have the website up for you. But women who are thinking about infant feeding actually come across so many barriers, and I just want to talk a little bit about those barriers, and then we'll talk about some ways to approach. But one of the common barriers that's been found is this failure for physicians and other providers to really talk about breastfeeding, to really counsel families on the importance of making an educated decision on breastfeeding. So that would involve things like talking about the risks of not breastfeeding, and also making sure that people have that educational material and those places to go to take classes. And many women find that they have cultural barriers to breastfeeding, which oftentimes is sort of out of our control, but we can actually help to rein people in by encouraging mothers who feel they do have social stresses, people who may not support them in their world. We can support them to say, look, you can tell people that your physician, that your healthcare provider is encouraging you to feed your baby in this way. But many women still have barriers such as lifestyle issues and social conventions. So things like expected to, if a woman's a bridesmaid and she's expected to be there all night and the next day for the wedding and party and drink and pump and dump, there are those expectations that women have that are hard to get around when they just have a baby. Other things, women who are planning on perhaps working on their PhD or their master's, or they're going to play tennis or start jogging, or all the other things that women think would be sort of like vacation during maternity leave, as opposed to really focusing on the needs of their baby and infant feeding. And recognizing that breastfeeding, especially early on, needs to come from them, and pumping and bottle feeding oftentimes does not lead to long-term success. Many women find that they have lack of social support. They have families, their parents, grandparents, their partners are not supportive of breastfeeding or think that it's odd. And frankly, there are some racial and ethnic barriers as well. In some families, it's really like grandparent or another relative who does a lot of the support, particularly when women have babies quite young. And so, so oftentimes, talking to women about some of these barriers really helps them to think through this, and we'll talk more about that. Women face employment barriers. So we know that in the United States we have the break time for a nursing mother's law under the Fair Labor Standards Act, which is supposed to allow hourly workers to have breaks according to the needs that they have for lactation. There's no rules about how long the break is or how often, and it's not a paid break. But many women still feel like their job is not amenable to actually taking those breaks. So even though they may be allowed, so to speak, to take the break, they may not based on the type of work that they do. So one example is I had a pharmacist in my practice who works, she's the only pharmacist when the pharmacy is open. So the only time that she can take a lunch break is when she closes the pharmacy for half an hour. So she told me, well, look, I'm going for my 12-hour shift, I can only pump that one time because I'm not going to close the pharmacy for some other pump breaks. I see this also with like people who work in airlines, surgeons, women who are in very high-stress jobs where no one really can take their place when they are actually working. And sometimes there's lack of psychosocial support. So I've heard women say things like having their co-workers make comments to them or make fun of their milk in the refrigerator, and other sort of intimidating situations that makes them very uncomfortable, maybe being the only women who have ever done this, and having colleagues in their offices, co-workers who are not willing to pay when they take those breaks. And then, of course, there are other challenges for working moms, such as childcare. Sometimes childcares are not super supportive, and there have been initiatives in this country to actually work on breastfeeding-friendly childcare sites. Infants sometimes change their behavior too. Sometimes when babies go to daycare, they like to check out and sleep a lot more and perhaps not eat as much because they would rather nurse. And so then when mom comes home, the baby will nurse very frequently in the evening, and then sometimes do something called reverse cycle nursing, where the baby will be up a lot more at night. So you may hear this from some of your patients. When they go back to work, they may say, starting at 4 months or 5 months, suddenly my baby who had been sleeping well at night suddenly is not sleeping well. and nursing much more often, and that might be the reason. Some women find that their milk supply changes during lactation. For most women, it will drop a little bit because they're not pumping as often as they normally would nurse when they're with a baby. Sometimes their supply is driven up because they're very sensitive to the effects of the pump, and the pump demands more than their baby would demand. And then there are common medical deterrents, so women hear about things, they also experience breastfeeding problems with their first or their last baby, so things like pain, having a history of a low supply, or worrying about a low supply. An excessive milk supply is actually a huge problem for many women, and probably 20 to 40% of women who I see in my lactation clinic actually suffer consequences of excessive milk supply. And then many women who have chronic illnesses, particularly autoimmune illnesses, who are needing to take various medications that are sometimes viewed as being challenging with breastfeeding or possibly deleterious to the baby, oftentimes may not even initiate breastfeeding for that reason. And sometimes women are just told to pump and dump. So women, I had a woman recently who went to immediate care and was told to use ibuprofen and to pump and dump. So there's that lack of knowledge out there about breastfeeding. So what I recommend doing when you're looking to support a mother in your practice, first I recommend starting out with a statement of how do you plan to feed your baby, as opposed to saying, what do you think about breastfeeding? Because as soon as you talk about breastfeeding and she's ambivalent, she may clam up and not really tell you what she's really thinking. So if you just start out by asking, how do you plan to feed the baby, you know that she's going to feed the baby something, and so the question is, what will it be, and what are her plans? Because she probably has plans. She's probably figured it out to some degree. And so if she says, well, I think I'm going to bottle feed because of whatever, that's your sort of your opening to talk about, well, tell me more about that. What are your barriers? Why are you thinking about bottle feeding, which would be formula, as opposed to breastfeeding? And so sometimes they'll talk about, well, I had this problem last time, or my sister had this problem, or I'm anticipating going out of the country, flying, being apart from my baby starting at 3 weeks because of my job. And at that point, I would strongly suggest that she consider having an individual prenatal counseling session with a lactation consultant, because oftentimes women don't realize that there are so many options for them in terms of pumping, in terms of partial breastfeeding, and then she can have a breastfeeding plan. So there are many, many barriers that women perceive. Sometimes they're social, and so that sometimes takes education. So in terms of prenatal counseling, I think it is important to share with families that breastfeeding is important, and that's normative feeding for the infant, and that infants actually have different health risks if they are formula fed as opposed to breastfed. And I'm not going to go through those in detail, but I think particularly well, I live in Wisconsin, so, well, really everywhere in the country goes through flu season, but in Wisconsin it seems like it's particularly hit hard. But basically we want to share that it's important for babies, particularly entering that cold and flu season, when kids go back to school, influenza's hitting, families are getting together around Thanksgiving and Christmas. Those are times of major illness, and particularly for a young baby, we want that baby protected, and breastfeeding is going to protect that baby. So babies who are breastfeeding have fewer ear infections, but they also have fewer really deep, serious infections like pneumonia, meningitis. They're less likely to become septic overall. And then addressing any breast concerns, ask mom, do you have any breast concerns? And this is a little tricky regarding the prenatal breast exam, because it's really difficult to look at breasts and say, gee, I'm really worried, like I think you may not make enough milk, or identifying any other problems ahead of time. So we don't have good data on looking at breasts and prospectively sort of using an educated guess as to what may happen, but we can reassure and say, you have normal breasts. And what's also super reassuring is if a woman says, well, my breasts grew and they were achy in the first trimester, that's a fantastic sign that the breasts have differentiated appropriately in order to develop that glandular tissue to make sufficient milk. So if a woman says, I just can't imagine that my breast will actually make milk, or I'm worried because my sister didn't make any milk, I'm talking about her prenatal development, and if she did go up a cup size and her breast felt achy, that's so encouraging. If she has flat nipples or inverted nipples, she does not need to do any nipple preparation because the baby is not latching onto the nipple. The baby is latching onto the breast like a big fat sandwich. So the baby will draw that nipple out. So there's nothing to worry about and no preparation needed. If she has a nipple ring, if she has a piercing in her nipple, I would suggest taking that out because some women are at risk for mastitis during pregnancy, and so that would be sort of like a wick, so I'd probably have her take that out. But having a history of a piercing is not a problem for breastfeeding. And then I strongly recommend that we have women gain some sort of education. And the analogy I make for women who say, you know, it's natural, I'm really not worried about it. I say, look, when your child is 13, are you going to withhold information about pubertal changes? You know, if you have a girl, are you not going to tell your girl about what happens when her period comes? It's natural to get your period, but we want her to know we want her to know what happens and what the consequences are and how it all works, both not only physiologically but socially. And so it's the same thing for breastfeeding. They really need to understand. And so many women will say to me when they see me that it's amazing how they've learned so much about their bodies and how they appreciate that so much. For women who don't have access to a prenatal class or want additional information, there is a lot of information out there, oftentimes from your own breastfeeding coalition, from your state health departments and state breastfeeding coalitions oftentimes have great information, in addition to WIC has great information. And in addition, womenshealth.gov/breastfeeding and the Leche League International.org are great online resources for breastfeeding information. And then I would also discuss employment concerns because many women who are going back to work have questions about how that's actually going to work. And that may be a time that actually referring her to a lactation consultant just to talk through how to manage at work. Is she using her pump correctly? How frequently should she pump? Human milk storage, all those issues. That's a great reason to either go to a mom and baby class postpartum, breastfeeding support class, or see a lactation consultant. And then I encourage you to create a breastfeeding-friendly office for yourself. It's very important, very, very important. I can't stress this enough. If this is the one message that I want you to attain when you leave here, it's not giving gift packs of formula because you're really an agent of the formula companies. Their goal is really to sabotage breastfeeding to increase formula sales. And so if you give that gift pack of formula, that's implying to the mother who you're trying to support that, yeah, I want you to breastfeed, but you know, you're probably not going to be successful, so you'll probably need this, or every woman eventually needs this. And every woman does not need it. We want women to breastfeed for at least the first year, and there's no need for formula at that point. So it's very important not to, it's not a gift. There are so many other things you can give a family, but giving formula is not a gift. It's actually sabotage. And then provide advice for early success. So I think it's very helpful for families to get to learn about what's going to actually happen when they go into the hospital. That the baby will be rooming in, that the baby may be put skin to skin depending on what's happening in terms of your baby-friendly steps that's happening at your hospital. And so, but having them understand exactly what's going to happen can make a big difference in terms of breastfeeding initiation, because sometimes they have certain ideas of what will happen, particularly if they were at a hospital that had not initiated any baby-friendly steps with past babies, and suddenly they're responsible for changing the diapers, and the baby doesn't go to the nursery, and then the baby's put to the breast, and they may wonder, well, wait, this is so confusing to me. I'm not quite understanding what's happening here, and that in and of itself may actually make it difficult to be successful with initiating breastfeeding. And then as a provider, I strongly recommend that you have close follow-up after discharge, ideally within 24 to 48 hours, depending on the situation. And then in your office, also just having comfortable places for moms to nurse. So teaching your front staff that if moms walk in with babies and the front staff can tell that the baby's acting hungry, maybe is rooting, crying, a lot of front office reach out. I think most people can identify that a baby's hungry. To offer that mother, would you like to nurse there in the waiting room, or would you like to come back to a room to nurse? So if you have extra space, that would be such a nice thing to offer. And then having, a comfortable chair, and in my office I use a nursing pillow that we can clean after every use. And then having visual messages that are positive and really avoiding messages about bottle feeding. So avoiding paraphernalia that's sitting around that supports formula companies or bottle feeding in general. And then addressing breastfeeding concerns throughout visits, whether you're OB and you're doing the 6-week visit or the 1 to 2 week C-section check, to talk about, just to ask how breastfeeding is going. And throughout well-child visits, it's important to ask about infant feeding. Many women actually don't think that they should talk to their doctors about breastfeeding because they think doctors don't know anything about it, and that breastfeeding, that all the breastfeeding support comes from nurses and from lactation consultants and the Latching League. So they'll actually possibly be shocked if you start asking them about breastfeeding. And then provide community resources. There are lots of community resources usually wherever you live, and finding out about the resources that are offered, or oftentimes there's a compilation of resources that's available through your breastfeeding coalition in your community. And then I have found over the years that supporting my breastfeeding employees in my office, my nurses, my medical assistants, receptionists, is fantastic because they are the ones who are the cheerleaders for my patients. They like to talk like little things about, like, have you tried this product? Have you tried this pillow? They'll talk about like their own experiences with breastfeeding and things like little comments that they may have made to their families when families say negative comments to them. So they actually develop this little bit of a peer support, and they probably do in other ways. You probably know that your patients are talking to your staff about all kinds of other things, and oftentimes they live in the same community, their kids go to the same school, and so they know each other pretty well. So having that cheerleading section in your office will come about by supporting them. So in conclusion for this part, primary care support for breastfeeding increases breastfeeding rates. We know that from the United States Preventative Services Task Force. We have many cultural, educational, and employment barriers to successful breastfeeding, and prenatal support can include literature, web resources, or a lactation consultant, and supporting office employees who are breastfeeding is a win-win situation for you and your patients. Okay, so let's move on to a delay in lactation. So this is one clinical problem. So I wanted to step back and first talk a little bit about physiology. So we know when women are pregnant, those hormone messages that allow our breasts to develop, that allow women's breasts to develop, come from the placenta. So the placenta spews lots of hormones that that have those breasts differentiate during pregnancy, and then so they're ready to go to make milk. But that same placenta does not allow that high prolactin level during pregnancy to have an effect on those lactocytes until the placenta goes away, because we have to get rid of that high progesterone and those high progesterone and estrogen levels that are there during pregnancy by getting rid of that placenta. So once the placenta is gone, those hormone messages go down, those hormones go down, and then that's when prolactin can be effective at the breast. Why over the course of the next 2 to 3 days, we gradually see the colostrum come in, and then gradually, by 2 to 5 days, we're seeing an increase in fluid with increased blood flow, oxygen, the breasts feel fuller, and that fullness is actually interstitial fluid. Initially, it's not a ton of milk right off the bat. So initially the milk is colostrum. It's very high in white cells, it's very high in beta-carotene, which is an antioxidant, very high in protein, very high in immunoglobulins, and some of us call it glorified pus because it's so sticky and rich. And so on the left is colostrum, and on the right is more mature milk. And then there's a transitional milk that happens in between, as the milk more fully comes in, after 36 to 72 hours, and that initial milk until about 3 weeks looks pretty yellow, so it still has a high amount of beta-carotene and immunoglobulins and protein. So generally, colostrum has about 5 to 10 mLs on each side per feeding, and babies are nursing at least every 1 to 3 hours, and so it's not uncommon for babies to wake up and to really cluster feeding quite a bit when they are awake, taking small volumes, and weight loss is really normal. It's normal for our culture because many women do receive IV fluids as well, but 5 to 10% of weight loss I think is pretty common, almost expected in my patients at least. But what we find, what we know from research, is that the more often a baby is feeding, we see milk coming in faster, and I would say that research shows that, and I definitely see it clinically as well. So I just want to point out that last month in August, the American Academy of Pediatrics published a great paper entitled Safe Sleep and Skin-to-Skin Care in the Newborn Period for Healthy Term Infants. And I'm not going to spend a lot of time going through this, but what's important here is recognizing that putting that baby to skin right after birth is very important, not only to stabilize the baby for many physiologic reasons, but also it facilitates early breastfeeding. And so we see babies actually latching on faster and getting those early feeds in earlier. And by continuing skin to skin throughout the hospitalization, we see babies being a little bit more organized and not having as many difficulties with latch. And the same thing with rooming in, which is another baby-friendly step. And we know that rooming in, the evidence shows that there's increased patient satisfaction and probably babies are safer. But again, we see an increased frequency of breastfeeding, which has been shown for more than 2 decades now, this issue with rooming in. And so by increasing the frequency of feeding, we see less hyperbilirubinemia. And if we see less hyperbilirubinemia, guess what? We don't interrupt breastfeeding as much and the babies are not as sleepy. And so rooming in seems to be associated with an increased likelihood of nursing for at least 6 months. So that early, again, I can't emphasize enough, that early initiation is so important in terms of eventual breastfeeding duration. We see higher volumes by day 5, and we see an earlier onset of lactogenesis too, which is that increase in milk volume. But if the babies are not really nursing well by 72 hours, particularly if mom is not pumping very much, her supply is really at risk because her body may perceive that the baby died or that there's no need to really bring on lactation. Her prolactin levels are going to drop basically. So we'll talk about why that is. So in the first couple of days of breastfeeding, it's very important that babies feed 10 to 12 times a day, and we want all the sucking to happen at the breast. So we really don't want moms or parents to be giving pacifiers to babies unless they really need it for comfort for some reason, like for separation or for a procedure. Because whenever babies want to suckle, they really need to be at the breast because, again, it's low volumes, right? So they need to get those low volumes. And that involves making sure that the parents are watching the baby and not all the visitors. So I think one of the problems that we have in our hospitals is that a lot of people march in and they congratulate and they bring gifts and they stay and they entertain and they bring champagne and all this stuff. Well, really what has to happen those first couple of days is that baby just needs to nurse quite a bit, and mom and dad or parent or whoever else is the partner, everyone needs to be resting when the baby's resting during the day, because guess what? That baby's going to nurse like crazy at night. The baby is used to being on an alternative schedule. So the baby's normal biorhythm at birth is to be very awake at like around 11 or 12, around midnight, when mom used to go to sleep, and then so that's when babies actually nurse the best. And so if moms are up all day entertaining, spending time on her phone, social media with all the visitors, she's going to be exhausted and want to send the baby to the nursery. That's when the baby's going to have the very best feeds. So cracked, bleeding nipples is also not normal, so we really don't want mom leaving with terribly sore nipples. She's not going to feed the baby enough, and that's going to have an impact on her milk coming in. And we want to avoid nipple shields, and nipple shields, we really just want to give the baby a chance. So I see no reason to have babies become imprinted with a silicone shield on the breast when we just need to give that baby a day or two to be successful at the breast naturally. And we'll talk a little bit more about nipple shields. So basically, in order to be successful getting started, we want frequent feeding, we want complete breast emptying, which will increase the supply. If mom becomes very engorged, she doesn't demand the milk by not nursing as often, if the baby doesn't really transfer milk well because the baby's very sleepy at the breast, that's going to drop the supply down. And engorgement in and of itself, just being very, very full, not only with interstitial fluid, but also making milk and then not not emptying the milk, will raise something called the feedback inhibitor of lactation, which is a protein within the alveolar space. And now we know that that is serotonin. So the hormones of lactation, we'll talk a little bit about this. The hormones of lactation are prolactin and oxytocin. Prolactin comes from the anterior pituitary, oxytocin comes from the posterior pituitary. So prolactin is the messenger that tells the lactocytes to make milk. And what's most important here is that nipple stimulation is required. So the only way to get prolactin levels up and to keep them up is that direct nipple stimulation, which is the better stimulation is going to come from the baby than from a pump. And that's one of my big issues about using those nipple shields in the first couple days, is that there's a blunting of that sensation of the nipple, and we have no evidence that using a nipple shield is allowing moms to maintain that high basal prolactin level. The other issue is that you can't measure a prolactin and estimate the amount of milk that mom will make. There's no correlation there because, you know, you have the prolactin's the big boss yelling at the factory to make the milk, but we don't know how big the factory is, right? She could have a huge amount of glandular tissue, she may have a small amount of glandular tissue, so you can't estimate the amount of milk being made by that prolactin level. And just increasing the prolactin level, like giving her medication like metoclopramide to increase prolactin, is not going to increase her milk unless she does the elbow grease of getting that milk out either through pumping or nursing the baby. So milk has to be emptied in order for the galactagogues substances that increase prolactin to work. Oxytocin is secreted by the posterior pituitary, and there are many sensory pathways. So as opposed to prolactin, which requires nipple stimulation, oxytocin is released in many different ways. So we all know that babies can hear, smell, feel, think about a baby and then let down, which is a problem for some women when they're back to work and suddenly their shirt is wet when they hear another baby cry. And so oxytocin stimulates the myoepithelial cells that surround the alveoli that allow that milk ejection. And many women identify, not oftentimes with their first baby, but oftentimes for sure with their second and third baby, they'll identify their letdowns. They'll feel a tight, tingly sensation. But again, if moms say, look, I never feel my letdown, that doesn't mean anything, because even some moms with 3, 4, 5 babies, they've never really felt that sensation of a letdown. So prolactin can be blunted, and the things that can cause the problem early on and really at any time during lactation are substances that will blunt that prolactin. So we know that smokers have lower prolactin levels, and over time they just don't keep up with the needs of the babies, and they often end up having to wean early because of smoking. Giving decongestants postpartum is very dangerous. I've seen many moms who've had great breast development. I saw no reason whatsoever why they would have a low supply, but they were given a dose of pseudoephedrine after birth because of having vasomotor rhinitis, very stuffy nose, maybe having a cold on top of it, and then losing their supply. Giving estrogen at any time is going to block those prolactin receptors, so avoiding estrogen is really important. So even giving a birth control pill at 6 weeks anytime during lactation, even though the CDC states that, I think it's level 2, that at 6 weeks you could consider giving estrogen. Really, I find that whenever I give estrogen, even if it's at 14 months postpartum and mom's still nursing, that's going to help to dry them up and help them wean. And then aripiprazole is one antipsychotic, which is an atypical antipsychotic, and that actually can drop the prolactin level. Nipple insensitivity, as we talked about, like a nipple shield, but also if mom has had a breast reduction, her nipples may not sense the baby as well, and that could have an impact on prolactin. A history of pituitary trauma, many of you as providers know about Sheehan syndrome, where there can be a partial infarct of the pituitary, but there's some evidence showing that maybe women with a history of traumatic brain injury might have some difficulty with their prolactin levels as well. Insufficient demand, of course, without adequate nipple stimulation is going to drop her prolactin level. And then hormone blockages, particularly testosterone, might cause a problem. So if a woman has thecal lutein cysts that occur during pregnancy, that this testosterone secreted may have an impact on her prolactin. So in order to raise the prolactin, direct nipple stimulation is necessary, as I have said before, and so the greatest response is going to come from infant suckling, but if mom has to rely on a pump, a double electric pump is going to bring that prolactin level higher than a manual pump or hand expression. So again, what we want to see is with nipple stimulation, we see increased prolactin and increased milk production. And then with the sensory stimulation of hearing, seeing, thinking, touching the baby, one woman will have increased oxytocin and her milk will let down. And then if she has ongoing fullness in her alveoli, the serotonin locally in those alveoli will rise, and that will have a negative feedback loop on the lactocytes and decrease her milk supply. So that's why that frequent emptying is so important in order to prevent the fullness and the increased serotonin. So this is an early feeding cue. Crying and screaming, those are really late signs of hunger, and those are times that it's sometimes more difficult to get the baby to the breast because the baby's disorganized. And so we want to catch these babies early, right when they're starting to put their hand, when they're awake and they're rooting a little bit and they're putting their hands to their mouths. But sometimes what happens is that the babies are just very sleepy. And if babies are very sleepy and they get to the breast and they really don't transfer milk well, the baby can become weak, the baby will lose weight, and then since the baby's not transferring milk, the mom's milk goes down and the baby is just even more sleepy. So I call that circling the drain, where the babies just are sleeping, becoming weaker, not transferring milk, and milk supply is going down. We want to see a positive cycle where the baby feeds well, this empties the breast, the milk supply increases, the baby gains, the milk supply goes up, the baby continues to gain, so we want to see that positive cycle. So let's talk about a delay in lactation. So what happens for women with a delay of lactation is essentially that their milk has not come in. So by day 2 to 3 for multips or day 2 to 5 for primips, they just don't notice that fullness. Now sometimes women, I have to tell you, sometimes women just have such their breasts are so full, they have so much glandular tissue and so many nooks and crannies to store that milk that those babies may be gaining like gangbusters and they never really feel very full. So there's always exceptions to rules in breastfeeding, and that's certainly one of them. So infant weight loss is really one of the most important features of a delay in lactation. So mom may say that she doesn't feel full, she doesn't notice any breast changes, but then the infant also is losing weight. Now I want to distinguish this from no milk. So there's a difference between noticing some milk, and then there's a difference between noticing no milk. And if a woman is 7 to 10 days postpartum and she says, you know what, my breasts don't even feel lactational, like nothing's happening even though I've been nursing my baby regularly, pumping my breast regularly, trying to give as much stimulation to my breasts, that is different than a delay in lactation. That's a medical, there's something wrong there, and there's a differential diagnosis to that. So what you want to think about would be possibly a pituitary insult, like thinking, did she drop her pressure? Did she become very anemic and need cells? Does she have a retained placenta? So if she still has like a cotyledon there with retained placental fragments, she may still be putting out some progesterone and estrogen, and so still blocking those lactocyte receptors for prolactin. If she has a fecal lutein cyst producing testosterone, that also will block lactation. And then if she's taking any medications or supplements, like if she was given, well, hopefully she won't be given anything like Discharge, but some women who've had hyperprolactinemia from pituitary microadenomas maybe think that they should start their Discharge or their cabergoline right after birth, and of course that will prevent lactation. And then supplements, and the biggest supplement that I see that creates a problem for some of these women is taking their placenta capsules. So it's become a trend in our area for women to have their placenta dried and then put into capsules, and they do this in order, hoping to like maybe bring their hormones down more gradually so they don't notice as much postpartum depression or postpartum blues. But however, you're actually giving back the hormones that you're trying to get rid of with getting rid of the placenta. So some women actually have a paradoxical increase in their milk supply with that, and they do fine, but I've definitely had women who've lost their milk and then they have to relactate over the course of the next couple months. So the medical evaluation, I would say if you have a woman like this, to really check out her pituitary, check a cortisol, check her TSH, and a T4, making sure that, because if the TSH is suppressed, it doesn't necessarily mean it's good. She could have a low T4 as well. Check her prolactin level, testosterone, and then if you check a beta-HCG, that's going to be high the first month or elevated the first month, but you should see a downward trend if she doesn't have retained placental fragments. And I think the other thing is that women need a debriefing. They need to understand, like, what happened? Why didn't any milk come in whatsoever? So that's the other reason to do this, in addition to, you know, counseling mom about the fact that she's not able to lactate. But getting back to the delay in lactation, meaning that her milk is going to come in, but it just takes a while for that milk to come in. There was a landmark study that was published in 2004 called the Darling Study. And what they looked at are the risk factors for that delay in lactation. So this was done among a cohort of women who were very, very motivated to be successful in breastfeeding. And they found that the first 24 hours, that 49% of babies really didn't nurse very well. And by day 3, 22% didn't really nurse optimally. And that 22% of these women did have a delay in lactogenesis. And more than 10%, and 12% of these mothers had excessive weight loss for the babies of more than 10% weight loss. So what were those risk factors? They included just being a primip, having flat or inverted nipples, having a BMI over 27, a prolonged stage 2 labor, C-section, some infant health, like infant health status issue at birth, weight under 7 pounds 9 ounces, using a pacifier, which can be a marker of this problem, and non-breast milk supplementation. So, so her milk supply, of course, may be delayed if she's not having adequate nipple stimulation. So basically, so I think this is a pretty common problem. Again, you know, the Darling study showed it was that it was 12% of these babies had greater than 10% weight loss. And I see this often clinically in addition. So what I do is when I see that it's maybe day 3 is usually the day that we see the lowest infant weight, and then it should start to climb because that's when we should start to see mom feeling more full, and then start to see the baby at least start to gain to some degree. And so if they're at that day 3, day 4, and I'm not really seeing any increase in milk, I look to see like sort of the horizon. So if mom says, you know, my breasts are feeling really much fuller, I don't know why the baby's not gaining, then I would think, okay, this baby's just really sleepy, we need to encourage this baby to take more, and sometimes they need to be supplemented with a bottle. And that's not really a delay, it's just a sleepy baby. And we'll talk about that. But if they're really, if they're up to that 10 to 12% mark of weight loss and really the breasts are not feeling fuller, I'll actually feel the breast too, do some manual expressions, see what I feel, and then that would be a delay. And so we want to make sure, so this baby's going to need to be supplemented, but we want to make sure that we're supporting lactation. So what are options of supplementation? Well, one would be, of course, her expressed milk, and it may be that if there's just a little bit of milk when the baby latches on, the baby may not take it because having a low supply really promotes that baby to fall asleep right away at the breast. The baby's not going to work hard to get those that small amount of milk. So sometimes she does need to pump in order to obtain as much expressed milk as possible and give that to the baby. Donor milk is an option in many communities, and many hospitals that provide donor milk for their NICUs are starting to provide donor milk for the floor as well for supplementation. And then infant formula, of course, is probably the most common means that babies are supplemented. So how would we manage this? Well, first we want mom to nurse on both sides when her supply is low. And then we want to make sure that she knows how to use that pump, though, after she's done feeding. So it's one thing to say pump after nursing, but someone's got to show her how to use the pump. And one of the issues in the hospital is that when moms first start to use the pump, maybe the first day or two, if for some reason they're separated from the baby, they may not be putting that pressure up very high, which is reasonable because they're just getting started. But by the time they go home, we really need to make sure that her breasts are not perceiving a mouse on the other end with a pump that really does not pump very much with too low of a suction. So we need to make sure her shields fit properly, the flanges fit properly, and that she's using adequate pressure to really tell those breasts, hey, there's a baby on the other end, we really need to kind of get things moving with this breast. And then we need to supplement the baby after nursing, and ideally it would be nice to be able to supplement the baby at the breast with a feeding tube, and we'll talk about that. And then we want to make sure that these babies are followed 24 hours after discharge if this is identified in the hospital. And then usually by 5 to 7 days, if I'm finding that the milk supply is not picking up, I will use some herbal galactagogues, which I don't have time to cover today. So we're going to talk a little bit about supplementation at the breast on the next section. So in conclusion, regarding a delay in lactation, optimal support for breastfeeding early on can decrease that risk of excessive weight loss. That's the big thing. That's why I went through the spiel about like how to get started successfully early on, because we can prevent that delay in lactation if we can get things rolling. And And the risk factors, however, for delay in lactation are quite common according to the Darling study, and breastfeeding can be protected and supported during a delay in lactation. So let's talk about the newborn who just doesn't latch. And I'm sure many of you have seen babies who just they just don't latch at all. And so it's not uncommon, as we saw in that Darling study data, for babies really not to nurse very well on day one. So hopefully they will latch in that first hour, which is really their golden hour of being awake, alert, and then they kind of crash after that for a while, so it's not uncommon for them not to nurse well. By day 2, most babies are really improving their skills with breastfeeding, particularly if they're enabled with skin-to-skin and early feeding cues are watched for. But if mom finds that there's been no latch by 24 hours, I would definitely have mom start to use a pump. I would really encourage you to not put a nipple shield on, because again, you're now having the baby learn that to find the breast, the baby's looking for a nipple shield, and that's not the natural nipple. We need to give this baby a chance. So I think jumping into a nipple shield, it's just a little too early to be doing that. So we want to supplement the baby with colostrum and keep that baby skin to skin, and we'll talk a little bit about why that is. So for babies who don't latch, the most common reasons for this is, one, that they were given bottles already, maybe because of hypoglycemia or some other need for early supplementation. If mom has a low milk supply, if there are anatomic or motor issues, or if the baby's sleepy or premature or that late preterm status. So let's first talk about the sleepy premature infants. These babies fall asleep very easily at the breast, and so it's important, particularly if you're working with babies who are 35 to 37 weeks. Those babies are not term babies, and there's some recent research showing that even a 40-weeker nurses better than the 39-weeker, who nurses better than the 38-weeker, who nurses better than a 37-weeker. So every week these babies are better nursers. So a lot of times these early babies, they fall asleep at the breast, they don't transfer milk well, they look great at the breast, but guess what? They're fakers. They're just sleeping. They have sluggish suck-swallow reflexes. So those babies need to be, moms need to pump, they need to be supplemented until their breastfeeding improves. Some babies actually have become imprinted, as I said before, that babies can become imprinted with a nipple shield, they can become imprinted with a bottle. So they get a bottle, they get immediate reward, and that's what they're looking for when they come to the breast. And the thing about a bottle as a nipple shield is that they have a very firm stimulus to the palate, and that's what they're looking for then in order to feed. And the breast is a very soft stimulus to the palate, so that soft stimulus to the palate may not drive them to have that suck-swallow reflex like that firm stimulus to the palate. In addition, bottle feeding, it really, especially if the bottle's tilted upside down, there's like this immediate flow with low resistance, and it just is very easy for babies to bottle feed. So babies can essentially sleep and bottle feed at the same time. Sometimes babies become frustrated when moms have a low supply. So sometimes these moms who have a delay in lactation or who have insufficient glandular tissue, which we'll discover later, these babies by day 2 are mad. So they may have been latching, and then suddenly they just are ballistic, they're mad, they refuse to latch anymore. And then I think about maybe mom really has a low amount of colostrum. And so that's when I'll suggest trying to supplement this baby at the breast to keep the baby there, keep up the baby skills, but the baby obviously needs to be supplemented. So using a supplementer, either a feeding tube, this is a commercial supplementer in the picture, but a feeding tube at the breast with a syringe can be helpful. So babies have anatomic problems leading them to not latch. So if they're tongue-tied, they'll have trouble grasping the breast. If they have torticollis, if you have a baby that's only latching on one side and refuses to latch on the other side from birth pretty much, definitely pay attention to whether or not that baby has torticollis, because that's probably the most common reason for that. It's usually not the breast itself, it's usually the baby's not comfortable going to that side. Nasal obstruction is a reason why babies won't latch, because they're obligate nose breathers, and then when you have the mouth full, of course, they can't breathe through their nose. So that's a reason and why they won't latch at all. If they're having pain, they're just uncomfortable, and sometimes flat or inverted nipples can be a problem. They just have trouble grasping the breast, and that sometimes is also an issue with the way that the mom is holding the baby as well. And then of course engorgement, because engorgement oftentimes this will lead to babies to stop latching. Perhaps they were nursing well before, and then they get to the breast during engorgement and they just can't find those landmarks anymore. It's like trying to grab a tightly blown up balloon. If someone throws you a balloon and you're trying to grab it in midair and it's so tightly blown up you can't grab it. And that's what happens with babies when the breast is engorged. So and with engorgement, of course, we'll work on a number of other issues to reduce that engorgement. But I just want to talk about a little bit about skin to skin. So if babies, if they're not nursing because they perhaps are looking for that firm stimulus, which is one of the most common reasons, from a bottle or nipple shield, is starting skin to skin. And if you think about holding that baby skin to skin, that baby will start to bob and peck. If you think about what babies typically do when you hold them, especially newborn babies, they'll bob and peck, and then you almost feel like the baby's jumping out of your arms, and you wonder, why is this baby jumping out of my arms to one side or another? That baby is looking for the breast. This is the repertoire that babies use in order to find the breast. And the baby, if mom is partially reclining and she's skin to skin, and she allows the baby to bob and peck and then fling to one side and she supports that baby, the baby will use its cheeks in order to move down towards the breast, find the nipple, and latch. So it's sort of like when you're trying to teach someone to pitch a ball, we don't really want that young Little League pitcher to stand there and just throw the ball. We want that Little Leaguer to do the things that he needs to do, like move, spit, touch his hat, whatever he needs to do, wind his arm a couple times, and then throw, and he's going to be much more successful. That's his repertoire, and this is a baby's repertoire for latching. Why not a nipple shield? We already talked about that it might reduce the prolactin level. I also find that many of these babies don't transfer very well with a nipple shield because they have this thing in their mouth that prevents them from really getting deeply onto the breast. So if a woman is using a nipple shield, I would suggest that she pump afterwards to make sure that she's maintaining her prolactin level and that she's emptying her breast well. And I would say in general, I don't think that nipple shields really teach babies how to nurse. If the baby has not latched by discharge, I recommend double pumping every 3 hours. And there is a procedure called hands-on pumping where we're also having moms do some manual compression during pumping, which you can actually see at the Stanford website, some videos by Jane Morton, M-O-R-T-O-N, very easy to find if you search on your browser. And then we want that baby to be kept skin to skin as much as possible to use his own innate instinctual repertoire to get to the breast. And then for feeding, obviously you have to feed the baby, either cup feeding, finger feeding, or bottle feeding are options, and then really working with a lactation consultant. And then I guess the final thing I would say is encourage hope, because many women think, oh, my baby didn't latch, it's been 2 weeks, my baby will never latch. They can latch. This is one of the most instinctual things that a baby has to survive. I've seen babies latch for the first time at 3 months, 4 months, 6 months, and there are adoptees at 9 to 12 months who have latched for the first time. So it's not true that they can't latch. If parents can believe their kid's going to ride a bike without training wheels at 6 to 7 years of age, they should be believing that their infants can latch onto the breast. So in conclusion, there are several anatomic and physiologic problems that are associated with not latching postpartum, but skin to skin really does promote that early latching, and infants can latch for the first time several weeks or months postpartum. And that is it. So I'm ready to take any questions. The question is, when you mention a non-supplement of breastfeeding, what do you mean? Is there a medication besides the prenatal vitamins to help? I'm assuming that the questioner is asking me about galactagogues, maybe, to increase breast milk. So there are some prescription medications such as metoclopramide and a medication that's not FDA approved here called domperidone, which increase prolactin levels. There are many other medicines that do increase prolactin levels, like thorazine, buspirone will increase prolactin levels. I don't use those as galactagogues, but I do use sometimes metoclopramide and domperidone to increase that prolactin level, which can help to increase milk supply. But there are many herbs that increase milk supply as well. And one more common one is fenugreek, which I don't tend to use quite as much anymore, but there are several out there which could take that in itself is a nice long lecture.
And I actually had one question that I wanted to pose to you. I know that you mentioned that premature infants or those who are born prior to 40 weeks, the earlier they're born, the more difficulty they tend to have with something like latching. Are there any other groups that you have seen in your practice or in the research that might be more of a red flag to providers for some of these issues like non-latching or delay in lactation?
Right. Well, so one thing I would say is that if a mother has had difficulty with low supply or a delay in lactation in the past, that she's at risk again. So that's something to, to be aware of. So if a mother says, I had this problem last time, definitely having her talk to a lactation consultant during her pregnancy, talking about how to get off to a good start, is important. Although I would also share that women who are having their second babies, they make more milk the second time. All mammals, this is something that we share in common with other mammals, make more milk the second time and beyond. We tend to be better milk producers. So sometimes things that happen the first time don't happen the next time. Babies who are hyperbilirubinemic, I find that once their bellies are heading towards that 13, 14, 15 mark, they really become more tired and more sluggish at the breast. I think the other thing is that babies who don't nurse well, oftentimes it's a chicken egg thing. So if the milk supply is low, they tend not to be great nursers. And then because they're not good nursers, they're not really emptying those crevices of the breast where we really need to get the milk moving in order to tell the breast that, hey, there's a baby there that needs that milk. It ends up being this self-fulfilling prophecy. If you have a baby, if the milk supply is a little low, that little delay, and then the baby is not nursing well because the milk supply is low, it just keeps into that downward spiral. Other than that, babies who are hypotonic, who have like Down syndrome or other reasons to be hypotonic, babies who've, I think circumcisions, I find oftentimes after a circumcision, babies don't nurse as well, pain, babies who obviously have been supplemented are not going to have that drive to feed as often. So that, yeah. Let's see, there's another question. I'm an IBCLC and have seen that the nipple in the everter helps. So that was a comment. This person is commenting about something called the nipple everter that is like a little suction cup that helps to draw the nipple out. And I think that that is reasonable because if you can draw the nipple out when the baby's latching on, you can actually, the nipple will then stimulate that palate. So I agree that using an everter helps. One of the things I like to mention too, though, is I like to avoid a lot of apparatuses and expectations that mothers need stuff in order to be successful breastfeeding. So teaching moms how to roll that nipple out, how to do perhaps some what we call what would be reverse pressure softening around the areola. So if you think about a swollen ankle, that's edematous, and you push on it and you can see that someone has pitting edema, you can do the same thing around the areola. So if mom's really full and her nipple seems kind of, if a breast is full, the areola is full, the nipple seems flat or a little bit inverted, rolling that out and putting pressure on that areola to push some of the interstitial fluid back will help with latch. Oh, and you were talking about something called the supple cups. I'm not sure what the supple cups are. I wonder if that's like the shells. These are little apparatuses, again, that help the nipples stick out, keep them out. I find that a lot of women who have inverted nipples, when they start out breastfeeding, they have inverted nipples and they've had them during pregnancy and before, but once they start nursing regularly, oftentimes those inverted nipples will stay everted throughout lactation or not invert quite as much. Now that's not true for everyone, but in general I think we make too much of a big deal about inverted nipples that many babies, again, we're trying to get them latch on to the big fat breast sandwich, not to the nipple per se. Can you suggest alternatives to using a nipple shield? We see them used very frequently. Yes. So when I have a baby that's not latching, so I'm assuming that this is the first couple days in the hospital when the baby's not latching, it's just too early to just make a decision that this baby can't latch. And again, it's this whole issue of really believing in the baby, trying to figure out why is that baby not latching, and give the baby a chance, starting with skin to skin and letting the baby work and practice with that repertoire to get that baby to latch properly. Now, sometimes you're getting into day 5, day 7, and mom is frustrated, and at that point I think it's reasonable to talk about the nipple shield and talk about what the risks are, that there may be a decrease in prolactin level, a decrease in transfer, that we need to watch those babies very, very carefully with a nipple shield. And then if that seems to help and the baby nurses with a nipple shield, the problem is that sometimes you're doing three things. The baby's nursing with a nipple shield, then mom is pumping after using it, and then she sometimes has to supplement the baby. So 3 steps as opposed to 2 steps, which is feeding the baby in some way, whether finger feeding, cup feeding, bottle feeding, and pumping, and continuing to work on that self-led latch, on that skin to skin, and getting that baby to latch on his or her own. Now, if moms decide, you know what, I just want to try the nipple shield, it's reasonable to do that at that point, as long as there's informed consent. And that's one of my biggest concerns, is that some mothers, I think, will go out to Target or to another store and just buy a nipple shield, put it on, and just think, okay, things are hunky-dory, not knowing that their babies are really not doing well, they're losing their supply and the baby's not gaining. So we want to make sure that they understand the risks and that they're following up closely, someone knowledgeable has an idea of what's going on. And sometimes I do see babies who start out, who haven't latched, who start latching with a nipple shield, and then moms will practice taking away the nipple shield, and then eventually the babies get it and they do fine. So sometimes it can promote, but I just think that we want to do no harm, and because of the risks of nipple shields, we just have to be very, very careful with those. So in essence, the alternative is to continue to drive that natural ability to latch on one's own. One person who asked about the supple cups talked about a study that was done using supple cups for flat, retracting, and inverted nipples. I don't know that study. And around here, we don't usually use, I don't know what this product is, S-U-P-P-L-E. I'm assuming that they're like breast shells, but I don't know, but I'll look it up. But again, I'm big on just using the natural thing, using your fingers and rolling that nipple out. And over time, they stay out.
And it looks like there are no other questions.
Great. Okay, well, thank you so much for the opportunity to share some clinical breastfeeding advice.
Thank you, Dr. Eglash.
Yeah, take care. Bye-bye.